Thank you. So, while so we're not going to talk together, we'll talk one after the other. So there'll be no confusion. While Altamash gets ready, and I was listening to Krishna, two or three thoughts. I became a student of diabetes and endocrinology in '83. So that's a good 42 years ago. And the morning I was hearing the deliberation that things have not really changed in terms of outcomes. But the insulin, what it was 40 years ago, used to be a glass needle, 26 number glass syringe, 26 number needle, boiling before injecting, cooling it before injecting. It used to be a pain. Things have changed. The excuses have not changed. They still remain. I'll get addicted. My uncle lost his kidney. My brother lost his eyes. My neighbor lost his legs. They don't realize that they're missing out something very nice and delaying so that complications come in first. And then once complications set in, there's no way of going out. Yeah, so Altamash is ready. Uh, I'll handle the slides from here then.
I can do it from here also, sir.
Also,
Yeah.
okay. So the reason I gave you this preamble is because we are going to repeat the same thing in a different format.
Thank you so much. Good morning, everybody. This is a duologue, I think what our chairperson was trying to allude to. So we have multiple slides where each one of us would take you through different routes and different aspects of the insulin that we're going to talk about. Dr. Sheshadri has given us a very good platform about what we're going to talk, and taking out the fear of insulin, giving a positive aspect of using insulin in life, and giving a background of how a twice a day insulin is better than a basal bolus in certain cases is what is going to be our main landmark on which we cook up this story and take it for our patients, which is going to help us. So that's our disclosure. And this is the first case that I would like to tell you. I think first and the only case. If there's too much of a time, then we need to go for the second case. So this lady, Mrs. Sushma, name changed, who is around 52 years young and entrepreneur, sedentary lifestyle, which is a typical garden variety of a patient that we see in our daily lives in the clinic, comes for consultation with some tingling in the foot, frequent fatigue and lethargy. We have good amount of time, so I'm going to take good time to discuss the case. Has challenges in adhering to the given advice. Last two speakers talk about the same. And concerned about a busy lifestyle, we see here all doctors are also busy. Same is with every profession. I think we sometimes take a discount on the patient's lifestyle if they say that they are busy. We need to keep that in mind and should be there that the patient is actually stressed and busy for whatever reasons and is trying to delay insulin therapy because of the complexities of regimen and others. Now, when we look at her biochemistry, she's absolutely uncontrolled, fantastically out of her range, whether it is HbA1c or whether it is a post-dinner. EGFR is 89, LDL is 126. We expect LDL of around 70 over here. And if you look at her previous hemoglobin is 11.4 and the total duration of diabetes is 12 years. So more than 70-80% of beta cells have already gone over there. And if you look at another aspect, if you take it from her being an entrepreneur, she's having dinner as her major meal. She has used GLP-1 RA some time back but did not like for whatever reasons. Maybe she had too much of a nausea. She had maybe some gastric other issues over there. Gastric emptying was delayed too much. But however, she's on your Empaceta metformin with a family history of strong type 2 diabetes and CKD, which makes her also at high risk of cardiovascular and a renal disease. So here comes the main question which we are going to ask Chadha sir, that she says she's worried about initiating injectable therapy, which because she has used some once weekly GLP-1 RA in the past, and concerns about the complication. And she also asks a question that I want the therapy to well fit into my lifestyle so that it is easy to understand and convenient to adapt. These are the two main pillars that we are going to answer with this session, that how would we make her understand, looking at this horrible background that she has had an experience, and the convenience to adapt with her lifestyle. How do we do? Because this is what we see daily in and out. Sir, how would you look at this case? Can you just summarize in 2 lines and answer this question?
Okay, so yes, this is a You said young lady, so I'll stick with that. But 12 years of diabetes and far from control. So pretty poor control. And the tendency here, if I could ask two people, one from this side and that side, what is the next option in your practice? She's on Sita Empa Met. Someone from this side wants to say what? Yeah. Okay, so you would do that. Not because we're sitting in an audience. Okay, somewhere that side? Same. Someone wants to disagree? Arey, then only we have fun here. Everyone says same.
Why AGI is not used?
Exactly. Someone should say something.
Yeah, that was a very nice one. Who said AGI not used?
Yes. Why AGS?
You said? Okay.
No. Let's hear it. So one is AGI. Why AGI is not used? Anything else glaringly missing from this prescription? Sulfonyl.
Sulfonylurea.
So how many people here would like to use sulfonylurea as an option? One, two, three, four. No. So you don't like the idea of sulfonylurea. Okay. So five at least would like to use. And please, there are no right and wrong answers, so don't feel shy. Are we recording this or we just free for all?
Yeah, it's getting recorded. The green dot.
It is getting recorded. Oh,
Yeah.
then we'll be careful. But yeah, so this is good. So generally, what happens in practice? We say that three drugs. Now we should go on to insulin. Fairly long duration, good chance of getting you back towards normal A1C. And one of the so-called secrets of my practice is this: a new patient comes to me saying, "उसका इंसुलिन आपने बंद कर दिया था, इसलिए मैं आई हूँ." उसका डायबिटीज 6 साल पुराना था, आपका 25 साल पुराना है. सो दोनों सेम नहीं है. बट या दैट्स हाउ इट वर्क्स. If you start early, there are 2 or 3 studies from Korea which says that at diagnosis, type 2 diabetes, put them on the pump or on basal bolus insulin for 3 months and you get a fairly good remission in a large number of patients. I know people will not agree to this, but it is there in literature. So the best you could say is to start insulin, but no one will agree in practice. So we start with 1 drug, 2 drug, 3 drug. We're not getting into that argument. But literature says that after 1, 2, 3, 4, 5, 6, we have I think 6 classes. 4, 5, 6 really doesn't do much. The evidence may be that one drug reduces the A1C by 0.8 when it works alone. So we do simple mathematics that if there are 4 drugs, then they should come down by 3%. It doesn't work like that. The efficacy part goes on reducing. So probably what we have as a good option, talking science, is to add a basal insulin. She's failed with GLP-1 for whatever reasons. And our RSSDI, our own homegrown association, says that if you do not get to target with 3 OADs, then please think of using an injectable format, whether it is basal insulin or what else. And the other thing, could you go back? Yeah. The other thing is, please don't use insulin as a threat, as a punishment, as a scare. You've done something very wrong, and no playing with your toys for 3 days and go in the corner. No, please don't use. We are talking all about adults. We're talking about type 2 diabetics. So keep that in mind. Continue to be remaining empathetic, even though if you are getting very upset about it.
I think that's a very important lead what Sir just said, that you should not use insulin as a threat. In 2025, we talked to a patient who comes with diabetes that yes, there are 2 types of treatment. One is a tablet that you give orally, and 2 is an injectable treatment that you inject either in your arm, abdomen or thigh. Now this could be either a GLP-1 RA or this could be an insulin. That is how on first day we need to educate the patients. We heard in the last 3 sessions since today morning that we need to educate, and these are the 2 those sense of lines that we need to talk to each patient at the start. Depending on the indication, you would take it from there. A teacher is always a teacher, because I asked him a question, he's given me back this question. So he's asking me, what is the Indian reality and how do you consider while choosing insulin therapy? My chairperson said, why can't you use AGI? I'm going to answer that in the next coming slides. Why we have not used AGI? Yeah, you can sit and ask. Superb answer. So that is why we are waiting for. That's why this symposium has been special. There is a insulin symposium in this particular hall to relay, to move out the insulin fear from the physicians also. I have one question to everybody. What is trypanophobia? Since the question came in between. Yeah, yes, sir. Fear of needles, and people those who have some amount of anxiety or depression or something else in their life, some psychological disorders, they do have fear of needles. There could be fear of height, fear of closed spaces. So these are very routine normal things, and we need to bring the patient out of it. To me, a patient, if he says I can't take, I have a fear of needle, I said it's a calculated fear. You show the first dose in front of the patient and the patient will take. Try to give the first dose within your clinic itself if possible, or within the first hour of consultation, so the patient becomes more comfortable. So why this India, what is this Indian reality? What happens when we talk about Southeast Asian or the South Asians? Because we are developing diabetes at a younger age. Yesterday, since 2 days in Diabetes India, we're looking at sessions, we're talking about Indian people having diabetes less than 40 years of age. I think that's a huge burden that we're looking, progressing very fast from pre-diabetes to diabetes. The age is within 6 months to 3 to 5 years, most of the Indian pre-diabetics turn to diabetes. That's a huge burden again. Very high levels of abdominal fat. You can look at Dr. Chadha and my tummies. Even though I look at 50 and he's 70 years, our tummies are yet out, despite talking so much about with everybody, because we don't have time. Now mark this line. I said sometime back standing over there that every profession has its own issue. High insulin resistance even at low BMI. In this audience, if I take abdominal circumference of all of you, every alternate person or maybe every third person from the list will have that much abdominal circumference, and that's the reality. And the most important bar of all is the early and rapid beta cell dysfunction. This is one reason why we have so much of that Indian people or Indianness getting converted because of South Indian, South Asian ethnicity. That is what we call it as. Now, I know you all are staying at Taj, Novotel or Wyndham. Some people are with me. I can see some faces. I saw everybody's plate. Not 64%, but nearly 90% of our doctor's breakfast plate had carbohydrate. You look outside, too much of a milk in the tea. There is a toast, there is a rusk, and there are cookies, which is all loaded with carbohydrate and fat. I think we got to be very watchful and mindful about what we are dealing in our so-called, even if we are on a holiday, we got to be very careful about what we are going to eat. And that's why we got to come out of the carb issue. And another important thing, not just 60 to 70% of carb that we eat from the STAR study that we have the data, but also about what happens about the food that we are eating. So would you like to throw some?
Okay, so traditionally, we have 3 meals. So we say 3 meals, 2 hours postprandial. But what we don't forget, we forget, we don't realize is that this goes on into the post-absorptive phase, 4 hours, 5 hours. So the true fasting is hardly 4 or 5 hours at night. And another bad habit most of us have is to have a late dinner. And as this lady also we talked about, come back home, heavy meal, and at times sleep immediately after a meal. No time for digestion. So the high starch, high carbohydrate content, low protein content, which is a double whammy. And that's probably the cost of food. Carbohydrates are cheaper and proteins are more expensive. But all said and done, we have to look at the blue bands, the dark blue and the light blue. That's the post-absorptive, the postprandial, and our therapy has to be directed there as compared to that green fasting phase that is there. So, that's what we need to keep in mind when we're thinking of therapy for this lady. So, I made this statement, Indians have a high PPG excursion, and it's important to target the postprandial glucose right from the start. We've learned over the years, fix fasting first. So how true is that for Indian patients?
That's another tough question that we have to answer. Thank you, sir, for asking that. Again, if you look at IMPROVE or the A1 Chief studies or the DIAP care, what we come to a conclusion is that the control of diabetes somewhere is lacking even with the strictest of the environment. The overall control of existing therapeutic armamentarium, despite having so many valuable treatment including insulin, the evidence says that the ppg contributes to a big level to hbA1cs, and the average control of hbA1c among Asian Indians.
Just 1 minute.
Yes, sir.
Before you go ahead, how many of you have go back to the previous slide? I want to know how many of you have heard these words: improve, achieve, A1 achieve, present, diab care. Do you know what these studies are?
Session.
These are cross-sectional studies done at different times globally, India,
Acha. Oh,
at good
yeah.
diabetes centers. I'm not talking of family plan. I'm talking of good diabetes centers. If you want the full article, you should get in touch with the Novo Nordisk people and they'll give it to you. And the figures that we are quoting here is the average A1C of patients with these so-called good diabetes centers. 8.9, 9.2, 9.2. We are nowhere near 7. Forget 6.5. This is the reality.
Right, thank you, sir, for that. And I think what we look at again is the despite similar reduction of fasting plasma glucose, lot less number of Asian Indians they achieve target with basal insulins. I think that's an important statement that we are making, that if you're using only basal and if you're fixing only fasting in a certain amount of patient, it may not give you the desired result, as we see with non-Asians versus the Asian population, without any significant difference in the dose of insulin. Earlier speaker.
What
Yes, sir.
again want to stress here is that we don't look very heavy. Hardly any one of us has BMIs of 40 and 45, but we behave like them. So for a similar BMI, we are worse off than the Caucasians, and for they do better even with their higher BMIs. And this is what has been shown in this study. Yeah. So the impact survey again, yeah.
This is what I think you also were trying to ask, that nearly 90% of the doctors preferred insulin therapy that would control both fasting and PP. Of course, this is years of experience, years of question, years of deliberation. And why is it that we are looking for that one thing which will control both? Because of ease of convenience, because of the adaptability. The question that the lady, Mrs. Sushma, our patient, asked, which I showed you in the first slide, that how can I easily adapt to that? So that's how.
Let me give you a little break. Anyway, what insulin do we consider? We have got about 7.5 minutes now.
That's another question that we will answer now, that what insulin we consider. Now, if you look at the aid for insulin decision, how many of us start the insulin dose arbitrarily? Just on a guess, start with 10 units or 12 units. We think some arbitrary point in a patient. If the patient is obese or severely insulin resistant or severe insulinopemic or a very highly uncontrolled, you start with a higher dose. But maybe some guide that we look at, that if your PP more than 180 plus 74, if it is in that range, you would look at starting at around that particular range, and how much you want it to be reduced, whether pre-mixed choice 1 30/70 or a pre-mixed 50/50 is what you are looking at. So the value is taken by calculating your ppg for diagnostic cutoffs, and 40 milligram is taken by calculating this ppg for diagnostic cutoffs for pre-diabetes, that's impaired glucose versus the impaired fasting. So the glucose excursion or the aid for insulin decision, how it would come, and when you want to fix both fasting as well as PP in the same patient at the same time, you are going to look at the evolution, which is not actually the revolution as we heard earlier. So that is where it comes from, a type of an insulin where we call it as a co-formulation, and we prefer here not the premix but we prefer a co-formulation, and that's where the three types of insulin are over here. That's the biphasic human insulin. We've used this left, right and center when I was doing my MBBS 1996. Then came this nearly biphasic analogs just at the time when I was doing my medicine, and then now when I'm into endocrinology and into practice now. This is their past few years now, around 12, 15 years we are using it already. So that's where we are looking at combination of degludec and an aspart, and that's the reason we have a co-formulation. Why? Because of the reasons that we discussed in the earlier last 5 to 7 slides. What it is, it's a combination in the same liquid, in the same
Solution.
cartridge, in the same solution of two insulins. That's 30% of the short acting aspart and 70% of the ultra long acting degludec, and that's what makes it this, and that's the fixed ratio co-formulation. There is no need of suspension, there is no need to tilt the pen or roll it very hard, and there is no interactions, and they retain their individual properties. That is an important aspect that we're looking. And most importantly, remember Mrs. Sushma, our patient, what she asked: how can I use it easily, and how can I make it easily adaptable to my daily routine? And that is where it comes, the management of both fasting and pp with this type of co-formulation. So that brings us to another question: what does this evidence say when we have to consider co-formulation over a basal insulin? Let
So this just one small study we want to talk. Okay, I mean, these are the features, the advantages of using a co-formulation: efficacy, safety, quality of life. So it's comfort, quality of life, flexibility. I want to have, because I'm a working person, meal timings may change a little. So I want that sort of flexibility, and all this comes with the co-formulation. So that's the advantage that you are giving to your patients. And there's one small study that we just want to put. Yeah. So that's about 300 type 2 diabetics not well controlled on oral antidiabetics, insulin naive. So they were divided equally between either the co-formulation, the OADs were continued as before, versus insulin glargine. This was over a 26 weeks period and treated to target. So what was important is that because we are treating to target, the fasting plasma glucose values are about the same, but the A1C reduction was better when the co-formulation was used. And the PPG control also was better to the extent of 57 milligrams per deciliter. Next. Yeah, okay. Now, the bugbears that we have or the patient has is one, we keep talking about weight gain with the therapy, and the bigger one is hypoglycemia. So, when you look at the left side, overall confirmed hypoglycemia with glargine and with the IDEG ASP, the regular overall hypoglycemia risk was about the same. But what really is scary for patients is the nocturnal hypoglycemia, and that's shifted towards the left. So it's in favor of the IDEC ASP. The glargine treated patients had more nocturnal hypoglycemia. So one of the important take-home point from these two slides is that for the same fasting, the A1Cs are better with co-formulation, and the risk of nocturnal hypoglycemia is also less. I'm not mentioning here, but eventually the dose of insulin also goes down. Yeah, so that's the diabetes treatment related quality of life score. And as it says that by the end of 26 weeks, the co-formulation treated patients were happier and they were happy to continue with that form of treatment. Next. Yeah, so nearly 80% of the patients who were on this co-formulations were at the end of the study were happy to continue with this. And from other studies, it has been seen that those who were being treated with basal insulin, they were happy to switch over to the co-formulation. So about 75 to 80% results are positive. Yeah. So again, sort of repeating that efficacy, no doubt, flexibility is there, and when you're thinking of converting from the basal to the, this is when you want to start, you can start either with one dose with the major meal, and when you want to progress up, so it's initiation, titration, and then intensification, you can go from one meal to two doses with the two major meals. So it doesn't necessarily have to be morning and night. It can be even afternoon and night with the two major meals. That's important. We've got a couple of studies in the special population. I think since we are nearing the end of our time, I just want to tell you that whether it's the elderly population, patients with renal and hepatic impairment, uh, patients undergoing the Ramadan fast from next month onwards, and the type 1 diabetic patients also. In each of these groups, in terms of when comparing it with the biphasic insulin, not the co-formulation, they did better. Their dosages were smaller. The risk of hypoglycemia again was less. So quickly, Altamash, in the last 10 seconds, if you can tell us how do we switch from the premix basal to the bolus to Idegasp?
So I think we are 2 seconds left, and very quick that we have to say is that it can be reduced in those experiencing only with hypoglycemia with other types of insulin. Otherwise, the ratio is 1:1. So that's very clear and a very important message. And as we saw, 74% of the people felt that they should be on the same kind of an insulin when they were shifted. Twice daily, again the same basal dose. Here, thrice daily, the same basal dose goes with Idegasp. And if the patient still is on 4 to 5 times daily basal dose, it's the conversion is nearly the same. I think that's a very important message we give, that switching needs to be individualized also without putting the patient into any chances of hypoglycemia, and that is how we call that this regimen is much more simple compared to others. Now, what happened to our Mrs. Sushma, for those who joined late, she was started on Rhizodeg and her HbA1c came down in 3 months to 7.2, and that's what was the target. Somebody said sulfonylurea, she wouldn't have got this much low without a hypoglycemia with. Somebody said AGIs wouldn't have brought down the HbA1c to this low. She was a 12 years diabetic, and here I rest my case. Thank you so much, ladies and gentlemen, for your patient hearing.